This is the second time that he has organized, and we have come here even before that. And I congratulate Dr. Calwin and his team for the excellent work that he has been doing here. And thank you so much for calling us here. And today's topic, I have been requested to talk on two aspects. Like actually one was supposed to be in the morning, but we have changed it to the afternoon. One is, you can project the slide. A very important topic. I think we have few cardiologists here. Dr. Madhavan and Kannan also can put their input into this. The main thing is bleeding and coronary artery disease. Basically bleeding and angioplasty. So this is itself is a very important and interesting topic with most of us may not be so familiar. And I also had an opportunity to go through all this because Calvin requested me to do this, although we have been treating these patients with whatever possible ways so far. One second, pointer. Okay. So, main objective of this study is to identify high bleeding risk. HBR means high bleeding risk patients, and decide on treatment, one, and understand is there any type of stent or some procedural need for such patients, and current studies on dual antiplatelet, which is a basic of coronary artery disease treatment, and what protocol should be followed if somebody has a GI bleed and he has coronary artery disease. So these are the main objective of this. So in a setting, how can a patient present with a GI bleed? Either he will have an acute coronary syndrome and come with history of previous GI bleed, or he can have a GI bleed and ACS at presentation, which is not common, which is very, very uncommon, and GI bleed just after angioplasty. So these are the three important scenarios you get, and how do you manage these patients? Why is it important means bleeding and thrombosis is a worst combination, because at one end you are bleeding, another one you are thrombosing. So how to manage? If you give anticoagulants, if you give antiplatelets, he is going to bleed. So if you don't give anticoagulants and antiplatelets, he is going to thrombose and die. So it's a very big problem, and definitely there is an increased mortality, and it's a tough management. But still it is possible. You can come out with a better outcomes if managed carefully. So why do you get high bleeding risk? Predominantly it is seen in very elderly patients: renal failure, liver disease, active cancer, anemia and transfusions, low platelet counts, and NSAID is one of the very, very important precipitating cause for this GI bleed. So keep this in mind, and to risk stratify, what do we have? We have two things. One is antiplatelet score, what we call it as precise DAPT score or DAPT score. We have certain criteria like smoking, diabetes, and there is a score. If the score is high, probability of bleeding will be high, so you'll have to keep them on a low dose of antiplatelet. Similarly, we have a Hasblatt's scoring, basically to see that if he has any high risk for anticoagulants. Probably these are two important scoring system which we have, which is really may not be so useful in our real-time practice. And we know that when somebody has an acute coronary syndrome, today the recommendation for dual antiplatelet is for at least 12 months, unless there are certain conditions where you can bring it down. So keeping this in mind, how to treat? So first, when somebody has a bleed, try to look at the modifying risk factors. There might be so many modifiable risk factors, we will just look into that. And when you look at the DAPT duration, should we give this double antiplatelet for 1 year as recommended by guidelines, or should it be only for 3 months, or should it be 6 months, or it should be lesser than that? It all depends on what risk this patient falls on, whether he is high risk, low risk, or intermediate risk for ischemia. So that is how we decide in our real-time practice, and we weigh this benefits in such a way that so that you balance both bleeding and thrombosis. And coming to high bleeding risk, what is the optimal stent or duration of antiplatelets we have? So for that we have some evidence. So there are so many studies where they have used different types of stents, and they have used different durations of antiplatelets, and then we have found that there is a possibility that you can select a type of stent. At the same time, look at the duration of the antiplatelet also. At the same time, when you look at the anatomical complexity also, can you reduce the duration of antiplatelet? Yes, there are many studies like which is, for example, Twilight or TICO or STOP DAPT studies, where they have stopped antiplatelet very early, within 1 month, and in some cases even within 3 months, even in complex angioplasties that we have done. And coming to stent type, this is beyond the scope of this talk today. Today, there is no difference between whether you use a biodegradable polymer or contemporary polymer or polymer-free stent. So that means you can use our standard drug-eluting stent of current polymer-based technology is at equal to whatever we have been studying now, biodegradable or polymer-free stents. Probably there is really not much of difference. Now coming to somebody with an acute coronary syndrome and an acute GI bleed, so what the guideline shows, actually in fact there is no guideline to say that if somebody has an acute bleed and acute coronary syndrome, how to treat them. But most of the guidelines, what I am telling you is from our experience and our protocol, what we follow. So when you look at this, if it's a very trivial bleed, then actually there is no need, you can treat like a routine patient. But mild bleed and moderate bleeding, in such patients, you need not stop both the antiplatelets, only aspirin is allowed today. So, but only problem comes is when there is a severe bleeding or life-threatening bleeding. So this is the spot where you cannot give any antiplatelet. I have seen a lot of my patients, what happens is the moment somebody has some gum bleed or some small little bit of hemoptysis, small blood clot in the sputum, their local physician, they try to stop antiplatelets. So that is really, really not good for the patient who have undergone recent acute, acute coronary syndrome and angioplasty. So any mild bleeding, don't do anything, just continue same thing. And if it is a severe bleed, probably life-threatening bleed, probably you will have to stop antiplatelet at that time. And very important, it's a very busy slide. I will not tell you anything. I'll tell you the summary of this slide. What it shows is, in very rare conditions, like when somebody is having acute bleed and then he is having stent thrombosis or acute STEMI or acute coronary syndrome, in such patients, you can withhold antiplatelet. Today we have short-acting bridging antiplatelets like cangrelol. So that can be used for this patient for a short duration until the patient stabilizes. And then probably in other cases, you just continue like this. And there is a definite role of endoscopy in all patients with GI bleed. And whether to do it immediately or later in a stable patient, first to do angiogram or endoscopy is still controversy. But generally what we do is, if the patient is stable, or patient is very unstable, what is the recommendation is, you do angiogram, you do angioplasty, you stabilize the patient, and usually between 12 to 24 hours after angioplasty, you take them for endoscopy. And only in a very rare cases, like probably active bleeding, it is still not common, very rare, there is no active guidelines. So what happens in endoscopy, all of us should be familiar. See, when you do an endoscopy in a bleeding patient, they can see 2-3 things. Very important is, if somebody has a liver disease, they should rule out varicose bleed. And probably that is very obvious with the history with cirrhosis and all those things. And most common upper GI bleed is non-varicose bleed. So non-varicose bleed is probably from the stomach or the duodenum. It's basically a peptic ulcer which is causing this. And what our gastroenterologists do is, they have certain combinations, especially some injections with epinephrine, and then they have some thermal and mechanical therapy to control the bleeding physically. They can inject it and then they can control the active bleeding, and then we can decide on our antiplatelets. So that is an advantage, and no guideline says that you should do immediate endoscopy in all patients with GI bleed. It is, I first stabilize the patient and do it within 24 hours if possible. And in most conditions you can continue aspirin, you need not stop aspirin, only question comes for dual antiplatelets. And even for platelet transfusions, if it is less than 30,000 or around 50,000, probably you can consider if he is having an active bleed. So that is what is the guideline says that. And they have certain classification on endoscopy, which we will not worry because as a cardiologist, but it is for the this gastroenterologist. They grade the type of ulcers and spots what they see in the endoscopy, and they treat accordingly. And very, very important, which anybody can do, even cardiologists, where they're general practitioners, surgeons, medical stabilization is the first part which saves a lot of patients. It is not a must that you should immediately jump in for any active aggressive treatment. Pantoprazole in high dose is very, very recommended, or you can give it as high dose twice a day or continuous infusion. Ryle's tube may be useful to monitor GI bleed, but it is still controversial. And other supportive case like antacids and blood transfusions is a must. This saves almost 95% of patients with upper GI bleed. So when you look at the guidelines, what the guideline shows is ideal recommendation for somebody who has a GI bleed is it is not 40 milligram of pantocid, it's 80 milligram of pantocid twice or thrice a day, prevents GI bleed, and even continuous infusions definitely helps this patient. What is recommended is until you do endoscopy, you put them on pantoprazole infusion or high dose pantoprazole, so your GI bleed can be definitely brought down, mortality. And as a cardiologist, when I get a patient with GI bleed, what should I do? So if it is a STEMI patient, that is ST elevation MI, so what we do is if he is having an active severe bleed, in mild bleed or moderate bleed, you can still treat like your routine treatment. But only in severe GI bleed, you consider to do non-stenting techniques, like probably you can do a thrombus aspiration. Today we can do laser therapy and just plain balloon plasty, stabilize the patient, and then you take him for endoscopy. And depending on the gastroenterologist's advice, generally if it is a peptic ulcer which is oozing, and they treat it thermally or with epinephrine injection, after that you are allowed to give dual antiplatelets. You can continue dual antiplatelets. And in non-STEMI patients who are really not in a hurry, if he is very, very stable, you can decide on upper GI endoscopy and take a decision. And most of the controversial or very unstable patients where he is actively bleeding, you can consider a cangrelor, which is, you can give it as an IV infusion as a bridging therapy until you come to know what is happening. So cangrelor is again an antiplatelet like clopidogrel or ticagrelor P2Y2 inhibitor. It is given intravenously, but the only advantage is the action goes off within half an hour to 2 hours after stopping this drug infusion. And of course, even in cardiogenic shock patients, there is no guideline, but recommendation, they say that consensus opinion, they say that it is better to do angiography first, treat the culprit vessel, and then later you do endoscopy and then take a decision. So this is a case example that what I have done in probably it is 2019 I did this case, a very elderly man who came with an upper GI bleed and TROP-I positive and very elderly man with LV dysfunction. He is a known cirrhosis patient. But on endoscopy, there was no varices. Actually, he was bleeding from peptic ulcer. So he was treated endoscopically with adrenaline injection. So he had a very significant left main disease. So videos are not running. Okay, anyhow. But when they transferred it to this laptop problem. Okay, anyhow, he had a left main triple vessel disease for which we had to do a left LAD stenting. And his score was like this, very high DAPT score, bleeding score, and then basically I had planned him for image guided angioplasty and then high dose pantoprazole. So these were the drugs that we gave at the time with small under expansion or malapposition, small dissection, nothing happens. But in a high-risk patient, when you stop dual antiplatelets, just switch them to single antiplatelet early, probably these patients tend to have a stent thrombosis and have problem. So technically speaking, in such high-risk patients, always try to do a simple, probably the best procedure, or without any complications. I think you should do that. So in this patient, we did image-guided PCI, and then he had high GI bleed, and we opted for a short duration of DAPT. So he was on dual antiplatelet for only 3 months, and after that it was changed to single antiplatelet. So to summarize, to take home message for you is, in trivial and minor non-GI bleed or even GI bleed, you don't stop antiplatelet, treat as usual, continue. And if the GI bleed is still stable and the patient is having acute coronary and ACS, you can always give preference to angiogram, and doing which is still, there is no consensus on that, I think, but angiogram should take precedence. Look at the anatomy and then decide on endoscopy. Preference is always for angiogram, and in most of the conditions, single antiplatelet is allowed. Dual antiplatelet, probably you will have to weigh the benefits of looking the endoscopic findings. Medical management with pantoprazole injections have a great value. Don't underestimate it. It's a very, very useful molecule. And in a very high risk group, keep dual antiplatelet duration short, probably 1 or 3 months, and then change over to single antiplatelet. And very important, to prevent GI bleed, we have agents here like PPI inhibitors, that is pantoprazole group of drugs. Avoid using NICADs. Eradicate H. pylori infection. That is a very important thing. In most of the patients, where most of the guidelines, what they say is, if somebody is on dual antiplatelet, it should be covered with the PPI inhibitors, like something like pantoprazole, to prevent GI bleed. So that is a recommended guideline. And coming to PPI inhibitors, there are so many molecules which to give. Generally, if you are giving clopidogrel, omeprazole and omeprazole are not recommended. It is basically pantoprazole which is recommended by all the guidelines. Avoid other PPI inhibitors, and probably there is a good evidence for long-term treatment for this, and I think we'll stop here. Thank you so much.
Thank you very much, sir. Your clear and elaborate talk on bleeding and dual antiplatelets. Now the subject is open bar.
Has done a great job all over the world. That is a very big, it's a proud thing for all of us, like as Indians, because there are so many other foreign valves, especially Edwards, as well as Medtronics, Boston, and all with those multinational thing. This valve is doing an extremely great job. So what it has done is, it has been implanted in more than 17,000 patients, plenty of publications, and then it is available in almost 75 countries across the world. And moreover, it is used in all aortic stenosis, aortic regurgitation, valve-in-valve procedure. That is, after surgical valve replacement, you can still use this valve and use it for valve failures after surgery. And there are all sizes. It can be used in tricuspid valve, pulmonary valve, and these are all the advantages of this MyValve, which we have been using for some time in our center now. So MyValve this is the aortic valve that has been designed. See, normally any aortic valve, there should be valve inside, and then this is how it is designed. Here we call it as open cell. This is the aortic end, and here there is a closed cell where there is a PET skirt plug which covers it. So this is how that aortic valve looks. So I will not go into the in-depth of all those things. What we do is, what we need to know is, for a basic thing, when you have a valve like this, there are different markers on this valve. So these markers are very important for you to place them across the aortic annulus. So when you use this, so what happens is, we have this dark band, light band, dark band, light. What you should do is, the second dark band should be placed at the annulus level. That is what is important. That is what we consider as important, so that it's an adequate placement of aortic valve in our procedures. So with this, what we have is, there are different sizes of valves which is not available in the other international brands. Like no other company in the world has this intermediate sizes, which is very, very important when you size the valve according to the body weight as well as the annulus. So that's a big advantage of this valve. And we have an experience of 30 cases from this period, and predominant, almost 14 has been bicuspid aortic valve, and 9 had severe calcification. Most of the cases, around 20 cases, we have pre-dilated. In rest of the cases, we have done without pre-dilatation. And in 7 cases, they required coronary protection. And these are all technical things which you need not worry. And this is what we have done in our center. When you plan for a TAVR, what is important is first we do a CT aortogram or CT angiogram. It tells you that this valve is suitable for TAVR. What we look into that is, we look at the annular size. We will look from the annulus how far the coronaries are. Because in the aortic valve, when you put a valve here, this valve can go and block the coronary and they can have coronary obstruction. So to prevent that, we should know how big or how far the coronary arteries are, what is the height of the coronary from the annular plane. So depending on that, we decide on how to implant it. But usually, if the height is more than 10 or 9, probably we think it is safe. But most of the time it is about 10, so it is safer. And then we look at the aortic annular size and decide what size of valve we should put. And we also look at the STJ junction and sinus of Valsalva diameter to decide what type of valve we use. So in this patient, what I have done, this is what is the CT report has given me. It tells me where is the calcium, how much calcium, whether it is bicuspid or the tricuspid. It's actually bicuspid valve, this case, it's severe calcification. That is what the CT is saying, so that to avoid embolization of this calcium also. And very important is, since we are doing percutaneously, the peripheral vessels are very, very important. If they have peripheral vascular disease and the vessel size is very less, it is very difficult to take the valve through this. So today, if the femorals are above 5.5, probably it is a good way that you can do this percutaneously with my valve. And there are some valves which are a little bit lesser, like self-expanding valves, probably can be taken up to in a vessel between less than 5 also. And this is the pre-dilatation balloon. So in this patient, what was recommended is, this is the aortic valve size that we have got, and pre-dilatation also was recommended because of severe balloon dilatation. So this is how the procedure looks here. So this is the aortic valve, and this is the coronary and the RCA and the LAD. Actually, I have done angioplasty stenting some 10 years before this procedure for this patient here. Now he has come with severe aortic stenosis. So what I have done is, I am just trying to enter the aortic valve. We have a certain technique, we have a catheter like Amplatzer catheter, and we enter the LV through the aortic valve. That might need a little bit of time, but it's not so difficult. And we change it to safari wire, more hard wire to support the valve, and we pre-dilate this valve with a balloon. And once it is pre-dilated, you see this is the valve going from the femoral artery into the aortic arch, and then we just keep it across the aortic valve here. So valve is going across the aortic valve now here, and it is getting positioned. So I am just positioning it across the aortic annulus. So generally what we do is, when you dilate this valve, this will occlude the entire LV output, so there will be no blood flow outside into the aorta. So to avoid problems at that time, what we do is, we generally pace this heart. So you see here, this is the pacemaker. We pace the heart to the heart rate of at least more than around 180 to 200. And while pacing, we deploy it. See look at this heart rate here. See, heart is beating very fast. You can look at this movement. When it is beating very fast, 120 because of the pacing here, I check the aortic valve position and I have deployed it. So this is how we do it. The advantage of this being very percutaneous, it is done under local anesthesia in most of the patient. Patient gets discharged in 1 or 2 days, and there is no need for a scar. There is no mortality. Actually, surgical aortic valve replacement carries a lot of mortality, which can be avoided in these patients. And it's a very simple, straightforward procedure, 1 or 2 days stay in the hospital. And after that, we just check for the peripheral arteries also to see whether there is any leak there, and we have specific techniques, perclose and other techniques to close the place where we have punctured in the peripheral artery. So I think this is the navigator system which comes with the valve itself, and this is a special sheath which is specific with my valve. It is called Python because this sheath can swallow the valve easily, just like a python. When the valve is moved across the sheath, it becomes bigger, and when the valve goes off like this, it again recoils, comes to the same size. So when it is in the peripheral artery or femoral artery, it expands and then gives way for the valve to go through it. And these are some of the examples that what I have, but I think we will skip here. So this is going through the Python valve, and if you can concentrate here, see that the Python sheath becomes bigger when the valve goes, and once the valve comes out of the sheath, it again narrows and comes back to the same size. So that is why it has been named as Python. It is typically Indian designed and made in India, and it is available in all over the world. And they have comparative studies also today called landmark study. And this is how we crimp. Actually, this valve comes in a small case. We will have to crimp it in the cath lab. So according to the size, you crimp it and then take it in the cath lab. That is what is done here. And more latest advancement is commissural alignment, that is planning for the future. Because when you put a tissue valve, see, percutaneous aortic valve, like a surgical valve, it is a tissue valve only. Tissue valve, even surgically placed, lasts only for 12 to 13 years or above 10 to 15 years. After that, it is going to degenerate. So, but unlike metallic valve, which is put in a younger patient, which is not put in an elder patient because to avoid anticoagulation. So this is also a tissue valve. So usually after 10 years or 12 years, it is going to degenerate. So in such patients, to do re-procedure, it is always better you get a commissural alignment. What we say is, when you deploy this valve, it should be aligned to the coronaries, so that if somebody develops coronary artery disease after TAVR, there should not be any problem in doing angioplasty in them. And I think with this, I will stop here. Thank you so much for the opportunity and the silent listening.
So thank you very much, sir.